Hello everyone, my name is Jane Roberts, Medical Affairs Dietitian at VitaFlow International Limited, and I'm very happy to welcome you to today's webinar hosted by VitaFlow titled Nutrition Post-Kidney Transplant. This webinar aims to support healthcare professional education with regards to the dietary management of paediatric kidney disease. A few housekeeping items before we get started. The webinar is intended for healthcare professionals only. The webinar will last about 60 minutes, and that will include time for questions at the end. If you would like to ask a question, please use the question feature on your screen. All the questions will be screened and a select number will be answered by the speaker at the end of the presentation. The webinar is being recorded and will be available on VitaFlow's website for healthcare professionals in a few weeks' time. PDFs of the presentation slides are attached to your screen for you to download. A CPD reflection tool and a feedback link will be sent to you via email after the webinar. Once your feedback is completed, you will receive your certificate of attendance. Financial support for this presentation was provided by VitaFlow International Limited, a Nestlé Health Science company. The views expressed herein are those of the presenter and do not necessarily represent VitaFlow's views. The material is accurate as of the date it was presented and is for educational purposes only and is not intended as a substitute for medical advice. Christina Nelms is a paediatric renal dietitian from the USA. Christina has taught nutrition classes through the University of Nebraska and has previously worked at children's hospitals in Omaha, Oklahoma City. She currently works at Children's Mercy in Kansas City as a senior staff member. She's the lead author for the renal chapter in the Aspen Pediatric Nutrition Support Core Curriculum and the pediatric chapter in Nutrition and Kidney Disease and Pediatric Dialysis. Christina is the chair of PRONA and a Pediatric Renal Nutrition Task Force member, creating clinical practice recommendations for global use. Learning outcomes for the session are documented on the slide.
Well, hello everyone. So we're going to be walking through the stages of transplant from preparation for transplant all the way through to post-transplant and some long-term implications. So we're going to be starting with preparation for kidney transplant. Now, this is an American guideline, but I've included it because it's a really helpful checklist for any dietitian or really anyone who works with the nutrition care of transplant recipients. It's for all transplants, but of course I'm going to be focusing on pediatric kidney transplants today. And this was a document that was created for competencies. Now in the United States, we have different regulatory bodies that manage transplant and make sure that professionals are doing what they are supposed to do and adequately prepared. So this document was prepared for the regulators to have sort of a checklist to make sure that professionals are doing what they need to do. However, like I said, it makes a really nice checklist for anybody globally who's working with transplant. And so these are competencies come up with this task force for dietitians who work with transplant patients. And to start off with, for preparation, it discusses the different things that the transplant dietitian should do, assessing patients, providing nutritional clearance, providing MMT to prepare the patient for transplant, educating transplant candidates and caregivers, and being part of the reevaluation for patients waiting for a transplant. So this is primarily focused perhaps for the dialysis dietitian or anybody who is helping prepare these the CKD dietitian who is preparing these patients for transplant. So some key points for preparation for transplant include weight management. So we know that underweight patients are at risk of having inadequate stores of fat and muscle for healing. Basically, a transplant is just a major surgery. And even though it's a pre-planned major surgery, it's still significant trauma to the body, and we need adequate nutrition going in. Likewise, there's a lot of recent data showing the risks of being overweight and obese going into surgery, including increased surgical risk. But specifically for this kidney transplant, we know that there's poor allograft outcomes, both in the short term and long term, for obese patients. And of course, we know that obesity rates increase after transplant, and there's therefore a higher risk of obesity happening sooner and more quickly. Laboratory management, we know that electrolytes being off is a contraindication for surgery. So certainly making sure our patients are optimized in terms of potassium, for example, is really important. Also, I think many families and patients think, oh, well, I won't have to worry about phosphorus after transplant, so I just need to get to transplant. Well, the reality is that having poor phosphorus control before transplant actually sets you up for long-term issues with phosphorus, including phosphorus losses, and actually greater allograft risks. And in fact, also poor vitamin D status or low vitamin D prior to transplant is actually a risk for the allograft failing. And then lastly, making sure we've educated our patients. At least in my practice, I think historically, again, patients think that transplant is a ticket to freedom, that there's no diet restrictions, they can eat whatever they want. And it's not that there's not diet restrictions, there's just new diet restrictions, perhaps not as strenuous as a CKD or dialysis diet, but certainly there are considerations that are important. So let's move on to immediately post-transplant. For the inpatient dietitian who is caring for that transplant patient, what do we need to consider? According to our competency checklist, we need to, again, perform assessment, educate, and develop a discharge plan for long-term follow-up. So when that patient is immediately in the hospital, typically because they've had a major surgery, they're NPO or starting fluids, and we do want to get nutrition going as soon as possible. Now, because many patients have what's known as acute tubular necrosis, or basically that kidney takes a while to wake up, so to speak, they may need some renal diet restrictions long term, so we need to prepare patients for that. Some patients can start a pretty regular diet right away. We need to encourage intake because they've had a major surgery. Many patients don't feel like eating, and we need to especially make sure they have adequate protein for healing. And in the first few weeks to months after transplant, where they still have a major surgical scar, the goal is 125 to 150% of the DRI for protein. And adequate fluid and food intake can be a barrier for discharge patients who don't feel like eating, and especially those who aren't meeting fluid needs to perfuse their new kidney. Now, when we switch over to that first 3 to 6 months when they're still in a healing phase and things are shifting around a lot, I would say those are often the most stringent diet limitations. Many patients have high glucose levels because they're on more steroids or other medications that can alter that. Sometimes because of the level of transplant medications, they need to limit potassium still for a while. Sodium is important for controlling blood pressure, and that's sort of a long-term need. And because many of our patients shift in the release, for example, even though you have a new kidney, it takes your parathyroid a while to possibly reduce if it has become enlarged and overworked on dialysis or during CKD. And so the body is often dumping phosphorus until that parathyroid stops overworking. So nutrition for the kidney donor. And I bring this up because not every facility does education of their kidney donors, but some do. And it's important to know what the needs for that kidney donor are if you're the one educating the kidney donor. So going back to our checklist, the transplant dietitian can assess donor candidates and any risks they might have, provide clearance for those donors, provide MNT when the donor might have barriers to donating that are modifiable, providing assessment and MNT during the hospital admission, and developing the nutritional discharge care plan. I know my facility specifically used to have the donors in our children's hospital to do the donation, and we were certainly responsible for educating that parent long-term, or who we had many parents, but whoever that donor was. It's now done at a neighboring adult hospital, so we no longer do that. But again, it really depends on the facility who has that responsibility. There are not great guidelines. There's a paper that was published in the Journal of Renal Nutrition that gave some guidelines for education for the donor, but there's very little evidence, unfortunately, on kidney donor needs. There's some. So this is an area that's really lacking if research interests are piqued on what is the best nutrition and evidence-based outcomes for the kidney donor. But based on these sort of rough recommendations, we know that there's a goal for promoting healthy weight long-term, limiting sodium, encouraging fiber, and that there may be a role with limiting cholesterol, moderate protein intake, especially encouraging plant proteins. We know that a solitary kidney can adequately handle a reasonable amount of protein, but the thought is, why push it with protein supplements or a high protein intake? Adequate fluid intake. Those who are heavier may need more than the 64 ounces, and not that caffeine or alcohol are contraindications, but for dehydration purposes, limiting those, and a general healthy diet. A lot of these are based on data that we know about persons with a solitary kidney, and it just makes sense to promote a good, healthful diet for long-term health, because some concerns for the kidney donor are cardiovascular. We do know that there is a slight increased risk, not only of long-term kidney disease, but cardiovascular disease and hypertension with kidney donors that is slightly increased from the public. There has been some recent papers discussing that weight management is probably the biggest risk for our kidney donors. We're learning that more and more patients or our donors are donating their kidneys as obese or overweight donors. The numbers, just because the population, especially in Western countries, but really kind of globally, we're seeing more and more obesity. Thus, it makes sense that the population that we have to pull from for kidney donors is increasing in weight. And we also know that living kidney donors as a source of donation for transplant recipients has kind of stagnated in the last few years, probably because our population is getting less healthy. And so it kind of becomes an ethical question about whether accepting kidneys from an overweight or obese donor is acceptable if we want to continue to be able to give people kidney donors. And actually, only 10% of the programs in the US exclude donors with a BMI that is considered obese. The others have either higher, 35 is pretty common, or no cutoffs. So the research has shown us recently that weight gain or Weight regain, if we've had patients lose weight to donate, is very common. Again, we have those surgical risks with obesity, greater long-term mortality risk, proteinuria, greater risk of hypertension, greater risk of diabetes. And we do know that the heavier the donor, the greater the risk for end stage eventually is. So that may be important to focus on for prevention in the long term for those who work with kidney donors. Okay, so this will be the crux of the presentation today, our long-term post-transplant nutrition needs for dietitians who are, and other professionals who are working with transplant recipients long-term. And I've included a lot of content in this presentation, mostly because I think it's helpful to have resources that you can refer to later. So some of this information I'm going to be going over fairly quickly. Going back to our checklist, the transplant dietitian provides MNT for patients with nutritional issues, identifies long and short-term transplant outcomes, and is knowledgeable in our micronutrient and macronutrient needs. Now, this particular document has some additional guidelines about that are maybe a little more focused on the guidelines we have in the US, like that the dietitian needs to have a certain amount of continuing education, working with a multidisciplinary team, et cetera. And if you're interested, you can read those on your own. But I'm just, for the purposes of this presentation, going to be focusing on MNT and the actual medical nutrition care that we give for medical nutrition therapy. So this is sort of an overview for macronutrients. We know that in general, the calorie needs are about the same as in healthy children. So if you're looking at international guidelines, we're thinking SDI for calorie ranges. The US term I've included is the EER, which estimated energy requirements, or whatever term is appropriate to your nationality for estimated nutrition needs. Weight gain is very common for a variety of reasons that we don't totally understand. It was previously thought to be medications, but we think just that patients suddenly feel good and want to eat again. All play a role in things. Macronutrients, again, the American term is the acceptable macronutrient distribution range, which is a balance of carbohydrate, fat, and protein. Again, whatever is relevant for your nationality. Unlike immediately after post-transplant for healing, our goal is to avoid excess protein intake, adequate protein intake, certainly for growth, but within that suggested dietary intake. And micronutrients, the goal is for adequacy, and certain micronutrients like iron, especially as the kidney declines, or we know that patients don't always have 100% kidney function after transplant. Sometimes those patients need some iron. So one thing I hear from some of my colleagues who maybe don't love transplant nutrition quite as much as I do is, oh, it's just regular healthy nutrition. But I think that we can emphasize the importance for transplant recipients of general healthy nutrition enough, because I'm so passionate about transplant nutrition because I feel like it's something we can do to potentially help the longevity of that kidney transplant and the long-term health of our recipients who are so at risk for so many things as immunocompromised patients. So certainly, and again, this is the American graphic of my plate, but I think worldwide we can know that increased fruits and vegetables is very important for nutrition. Importantly, focusing on cardiovascular disease is very important because we know our patients have a higher risk of that. Limiting saturated and trans fat. We know that there is evidence showing that omega-3 fatty acids can be really beneficial to our patients. And even possibly supplementing those. There is evidence, even though that is a bit controversial in the general population. And in fact, data shows an inverse relationship between essential fatty acids and blood pressure, triglycerides, and HDL. Now, even though this term Step 2 American Heart Association guidelines has been updated, I included it because it is the citation in the papers that originally promoted more of a heart healthy or low saturated fat diet. So limiting to 10% or down to 7% of saturated fat, et cetera. So just think low saturated fat, low trans fat. We know that dyslipidemias are a higher risk for graft loss and mortality, which to me is very significant. We need to be thinking about these sort of needs, even though they seem like basic common sense, good health for everyone, that they're extra important because they are a risk for graft loss for our patients. This comes from a recent paper on pediatric lipid management, and I include it because it's a bit controversial. On this left-hand side, I know the data is small, but I just wanted to point out that some different major guidelines between NKF, KDIGO, and the Pediatric American Heart Association sort of vary with KDIGO discouraging statin use, but the other two bodies saying, if appropriate, statins, even in pediatric, especially adolescent patients, is appropriate. And so this recent 2021 paper says, based on all the different consensus guidelines, it is okay, obviously starting with dietary intervention first, but to consider statins because dyslipidemia is such an important issue in our population. Just another thing I wanted to include for your reference, because I think it's quite interesting. It's a comparison of transplant recommendations in adults versus pediatric patients. So for those of you who work with an adult population and maybe dip into peds or want to know how these guidelines compare, this is just a side-by-side. For example, blood pressure is a set number in adults where it's based on age, sex, and height. And I'd encourage you to check out the pediatric blood pressure guidelines by the American Heart Association that stratify by age appropriate blood pressure goals, if you're unfamiliar with those. But it just nicely shows differences between adults and pediatrics for those age specific goals. So again, going back to general healthful nutrition, I'd like to highlight two studies that I think were really eye-opening that came out in the past few years, showing how great of a risk malignancies and diabetes are for our population. These were both based on populations in Canada, and they were long-term studies of former pediatric transplant recipients going into young adulthood and the risks for these patients for these issues. And what I think is really startling is that there's, for cancer risk, there's a 20% risk. That's 1 in 5 over 10 years post-transplant. We know a lot of these are skin cancers and whatnot. This increases to 30% by 20 years because our patients are immunosuppressed. 30-fold increase from the general population, and an 85 times higher risk of death from cancer compared to other patients who have cancer in our transplant populations. And although we don't have a direct correlation, I think we can extrapolate from the general population. We know antioxidant-rich foods like fruits and vegetables are preventative in the general population. So it makes sense that those would be appropriate for our patients who are at even greater risks. And we need to keep vitamin D in mind because to prevent skin cancers, many of our patients appropriately limit sun exposure, which means they may need more vitamin D intake. Likewise, type 2 diabetes, nearly 20% risk for our patients 10 years post-transplant, a 20-fold risk in the first year after transplant of developing diabetes. You can just see those long-term risks and the risks of death being so much greater than our transplant patients who don't develop diabetes, which really emphasizes why we need to have nutrition working with these patients for limiting sugar intake and exacerbating that that intake of high carbohydrate risk foods. And we have to keep in mind that that new kidney is what's filtering all that excess sugar loss in the urine and damaging to that kidney, and the importance of weight maintenance and prevention of weight gain. So we also need to think about bone health. Bone health is very important for these transplant recipients. We know that we have a lot of pre-existing bone damage when these patients were CKD patients. We know that it's a risk for cardiovascular disease when we've got calcification. We want to make sure they're getting enough calcium for their bones as well as vitamin D. We know actually it takes 2 years post-transplant for the bone loss to actually stop, because we know transplant medicines, many induce osteoporosis. And certainly if we're giving them higher levels of transplant meds for a rejection episode or at first, they're losing more bone. And so it takes a couple of years for that to normalize where we can actually be repleting bones. Another micronutrient of concern is hypomagnesemia, and keeping in mind that we need to either be using high magnesium foods or supplementing magnesium, because that's a risk for acidosis, which of course is a concern for growth and CKD progression. Sodium. Now, sodium is actually more controversial than you would think. Now, we do know that children with salt wasting disorders who aren't getting large amounts of sodium from an oral diet, like our formula-fed patients, do possibly still need sodium supplementation. However, the majority of our patients who are on a typical diet need to limit sodium, because we know that hypertension will damage a transplant kidney. You can see the statistics that many of our patients are poorly controlled, and it increases risks of graft loss. Now, there is not, unfortunately, a good ringer for evidence on which diet is the best for limiting hypertension in our patients, but we do know in general limiting sodium is probably a good idea. Some different diets that have been studied, Mediterranean, more of a plant-focused diet. It's really only the American Heart Association diet is the only one that has been well studied, but many of these diets, because of what we know from the general population, have been encouraged as possible focuses to control hypertension. Fluid. So I like to tell my patients and families that after getting their labs, so that our nephrologists can know how their transplant is doing, and taking their medicines, probably number 3 on the list in terms of importance for care of that transplant kidney is fluid. We have to perfuse that transplant kidney. It is not going to act like a native kidney. And we know that our young children get adult-sized kidneys because we need that kidney to last long term. So we don't give them child-sized kidneys, we give them kidneys to grow into, so to speak. So the recommendations for those young children are 2,500 milliliters of fluid per body surface area, which often equates to 50, 60 ounces of fluid for a toddler, which is more than they would typically drink. So we have to get them used to drinking those high amounts. And again, sodium guidelines are recommended for those who still need sodium supplementation. Some guidelines, depending on the size of that child or adolescent, anywhere from 1.5 to 4 liters of fluid daily. Some other guidelines for fluid intake are listed there. Ideally, we would choose sugar, caffeine-free beverages, milk or milk substitutes, and water are going to be our best choices. And many of our adolescents who choose to consume alcohol may need to be counseled about the risk for dehydration of that transplant kidney. I'm not going to go over these on the right, but just some tips for increasing fluid intake are on your right-hand side for your reference. Growth is something we also need to consider after transplant. Now, some recent evidence coming out of Children's National Hospital in Washington, D.C. indicates that about 20% of our patients, somewhere in there, 15 to 20%, continue to have risks for failure to thrive after transplant, which is associated with a higher risk of infections and hospitalizations, and have difficulty transitioning off of a feeding tube. And that is a different population. Sometimes we need to involve a specialized feeding team. However, typically we see a rapid weight gain post-transplant. We know that obesity and overweight percentages double, and that our kidney recipients are the most at risk, a high level of metabolic syndrome. Many of our patients, because they've developed lethargic tendencies from the uremia they've experienced as CKD patients, remain inactive. Also, contact sports may be limited for the protection of that kidney. Typically, in that first year, it's considered high risk to introduce growth hormone, but after that, it is appropriate for children who need continued catch-up growth or maybe still aren't growing at their optimal potential. And according to the assessment guidelines for CKD, we need to be addressing these patients and their growth at least every three months for less than 3 years of age and 6 months for older children. These weight management is a whole separate talk, so I'm just going to be including some highlights here. We want to really work with families to get that weight management under control before transplant, but also counseling them that even if their child is underweight or low on weight going into transplant, that may change, and to expect that and to prepare for that. Data shows that waist to height ratio in transplant recipients may be a more beneficial marker for the negative outcomes that come with being obese, cardiovascular outcomes. And there's a couple interesting papers you might check out on that. Making plans for physical activity and access to that. Encouraging weight maintenance or slow weight loss, basically letting children get taller if that's appropriate. Considering things like support and group-based weight management counseling, which is known to be more effective than letting patients do it on their own, getting the family involved, getting SMART goals or the time-sensitive, specific, focused goals, limiting screen time, and managing psychosocial concerns. Basically, we don't want to put our patients on rigorous diets that could be unsafe for growing children. So our goal is to limit simple carbohydrates and saturated fats as our primary means. This comes from the Pediatric Renal Nutrition Task Force. The recent paper on with the clinical practice recommendations on obesity and metabolic syndrome. I know this is small print, but it's just for your reference, and I wanted to just highlight the things in red. A comprehensive multi-component intervention, individualized energy intake, focus on diet quality with high nutrient foods emphasized, daily physical activity. Again, not any one diet fits all. It needs to be very individualized for that patient and their family and their lifestyle. Behavioral modifications, including things like sleep, screen time, psychological intervention. So, and there are some notes on medication and bariatric surgery as well. And this is kind of from the crux of the treatment part of this paper. So this is a summary of post-transplant nutrition needs for general nutrition, and then we're going to talk about a few specific issues more broadly. Again, this is just for your reference and a summary of what we've talked about. A couple key notes for enteral formula use. Again, sometimes renal formulas are necessary for patients with delayed allograft function. However, typically a pediatric formulation, a general pediatric formula, is appropriate once a kidney is functioning. And the goal is to work children off these enteral feeds, typically children with a good functioning kidney who feel better, even if they struggle to eat before transplant. The research shows many are able to transition within about 6 months to a regular diet. Keeping in mind that subset, that 15 to 20% of patients that have some struggle with failure to thrive and are severe texture averse patients may need some feeding disorder counseling. Typically, and I always am a big proponent of G-tubes prior to starting dialysis because we know that kids are often going to need them after kidney transplant, if for not nutrition, but meeting fluid requirements because of those high needs to perfuse that adult-sized kidney. Keeping in mind, kidney transplants don't last forever, and again, our enterally fed patient may need to consider a renal-friendly or a blended product as the allograft fails over time, or if unfortunately they have rapid allograft failure from an infection or whatnot. And again, just a reminder, we know the average kidney transplant lasts about 10 to 15 years, and that's why I'm passionate about the doctor I've worked closely with, Dr. Brad Wardy, would always say to patients, your first kidney is your best kidney. And that's why I think we really need to optimize nutrition and good health to make that first kidney last as long as we can. And just keep in mind that we may need to implement things like phosphorus restrictions once that PTH starts to be elevated in the transplant kidney. We know medications are nephrotoxic, they're necessary, but unfortunately we do know they lead to the decline of the kidney eventually over time. And certainly things like potassium restriction, protein limitation as that kidney becomes closer to needing a second kidney transplant or the restart of dialysis, as well as growth, are long-term factors that we need to be aware of. I'm a big proponent that the whole team needs to know what that creatinine is doing so we can have a trigger. Do we need to be thinking of changing the diet or other needs based on more of a CKD stage 4 type picture than a healthy transplant picture? So, one thing I want to talk about, because I think it's really important for this population specifically, is some drug, nutrient, and dietary supplement considerations. So going back to that competency checklist, it's recommended the transplant dietitian be very knowledgeable on food-drug interactions of transplant medications. And this is just sort of an overview of nutrition-related concerns with transplant medications. And keep in mind, our patients are on many medications. And if a patient is having a nutritional related side effect, it's worth checking out what medications they're on. And in fact, sometimes it's not even a transplant medication. Let's say they're on a medication for ADHD that sometimes suppresses appetite. And many of our patients just happen to also be on medications like that. This is a table that I've put together. It's been adapted from a couple different references, but just mostly for your reference on nutrition-related side effects of common transplant medications. You'll notice corticosteroids have a whole host of issues, which is why I know many of our physicians try to minimize steroid use, but many of our patients are on a lot of these, especially at first, are retreating a rejection. So we need to keep some of these things in mind. Calcineurin inhibitors, potassium is an issue that we should be mindful of. Low magnesium, some issues like that. Certainly induction agents. Many of our patients, especially at first, may have some GI side effects because they're on more induction agents. Drug-nutrient interactions are defined as interactions that involve stimulating the immune system or affecting the ability of the medication to enter or exit the body. And we know that about half of drugs use the same enzyme pathway, that cytokine P450 pathway, for drug absorption and metabolism. And some botanicals, some foods actually have the same absorption, grapefruit being a notable example of use of the cytochrome P450 pathway. I've highlighted here some of the biggest drug nutrient interactions we know, grapefruit juice, of course, being the one that's most well known, altering medication absorption. However, and actually increasing the absorption, which when we want to keep those medication levels in a tight range, too much and too little is a problem. There's some evidence that certain citrus fruits like Seville oranges and pomelo act similar to grapefruit, so they should be pretty tightly limited. Pomegranate was listed in that, but a recent paper actually kind of disputed that, so the jury's out on that one, but I would certainly watch it closely. Some papers that say some of these foods our patients certainly can eat, but maybe not in excess. Supplemental vitamin C. So we want nutrient-rich foods, but when we give supplements or megadoses of vitamin C, we may impair that immune suppressing response. Sirolimus, what we know is that food can impair the absorption. And so our patients are told, if you're going to eat, always eat, so they can adjust the dose for food intake. And if you're never going to eat, never eat. Don't change it up in terms of food intake or not food intake. Large meals or high fat meals can also change sirolimus. So the meal that, if it's taken at the time sirolimus is consumed, should be pretty steady. And star fruit should be avoided in any patient with CKD. So we know that 34% of Americans use herbal products regularly. 20% of adult pre- and post-transplant patients were reported to use these, which it makes sense that pediatric patients or parents are maybe using those. Again, grapefruit juice and St. John's wort are the biggie. St. John's wort actually inhibits the absorption of these medications, but there's other interactions. Fish oil may increase sirolimus levels. Now, many of our patients appropriately are prescribed that for lipids, but again, the sirolimus should be just adjusted. The U.S. National Center for Complementary and Alternative Medicine website, again, I'm American, so I'm familiar with American resources, and you might have yours based on where you live, but if nothing else, this is a good general reference that might be of help. This is a table that I've compiled. I last updated it in January, but one thing that I've worked really hard to do is review even small papers, even case reports of herbs that have ever been reported to have interactions with transplant medications. Now, the ones I've starred are ones where one or more patients were actually reported in the paper. The ones that aren't starred are ones that are more lab-based, in vitro, possible interactions. It's not to say that patients have to avoid all of these foods. It's saying, or even, well, I would probably advise them to limit the herbs or the supplements. But foods like garlic, we just want to maybe avoid in excess. So just this might be a helpful reference for you for things that have actually been reported in the literature, either in vitro or actual patients and cases that that could be a concern for patients if you're going over herbs and you see some of these. So grapefruit, one thing we have to keep in mind is that grapefruit, our patients may not be eating a grapefruit or drinking grapefruit juice by itself, but that grapefruit is in several, especially citrus-based beverages, and to be aware of potential hidden sources of grapefruit juice in foods. This is a website, again, it's American-based, but it still may be helpful internationally. I've included the website here for some it's actually from a cancer institute, Memorial Sloan Kettering, but it's super comprehensive and I really like it. And I've highlighted a couple of lookups. For example, turmeric. You'll notice down here that it indicates how it interacts, and then certain medications. Many of our patients take Tylenol. So there's a potential interaction. And the big one to note here is tacrolimus. So this is a great way that if patients tell you that they're on an herb, you can quickly go and look it up and see if there's any medications that they're on that might be of concern. This is just another example of that with peppermint. You can see a potential interaction with cyclosporin. And why I really like it is it actually shows the original papers where these reports came from. So I love this reference. This is one that's specific to CKD. It was developed in British Columbia. I don't like it as much as a Memorial Sloan Kettering because I think it doesn't have as much background information, but it is renal specific. So I think it's interesting. And the paper that talks about this database, I've just included some statistics here in the right-hand corner that they used for the basis of creating this website. I've created, and you are welcome to adapt this for your own needs for your transplant patients, some of the key points that we need to be considering to educate our patients in terms of drug-nutrient interactions. So just kind of a quick summary that should be easy for our patients to follow. Since there's so much data out there and so many details, hopefully this is a helpful reference to you for just basic, easy education for patients. We're going to talk in our last few minutes about food safety because it is really important for transplant patients. So again, our transplant competencies do talk about food safety. Now, again, this is American data because this is what I have access to, but in the US, transplant patients, we know many people are develop foodborne illnesses, and it may just be some diarrhea for a day or two in healthy people. But we do know that those at risk, which include our transplant recipients, are more likely to be the ones that are hospitalized and die. They're 15 to 20% more susceptible. And the data from other countries is pretty similar. And in fact, in countries that may not have westernized food safety regulations, these numbers can be even higher. So it's important to educate patients and families. We know that we have increased appropriate immune suppression so that the transplant kidney is not attacked. That's the purpose of our medications. But it means that they're more susceptible to infections from improperly prepared food. So data shows that our education has been inconsistent over the years and that there's some pretty significant outcomes, as you can read here, including allograft loss. In a liver or heart transplant, that could be deadly. Our patients would go back on dialysis, which is still unfortunate, and the longevity of the kidney. If possible, we should teach our families that if they know the food that might be suspect, to save it, because sometimes it can be reported to help other patients if there's an outbreak. I wanted to highlight this paper because I thought it was fascinating. This is actually a Swiss paper that looked at 197 solid organ recipients, not necessarily pediatric, but the message is the same. Only 18% follow all of the food safety recommendations, and typically this tapers off over time. The first year is the most for adherence, which is good since that's typically when their drug levels are highest, but 18%, not the same 18%, develop a foodborne illness within the first 5 years after transplant. But their data showed that the patients that reported stringently following all food safety guidelines, none of them were in that 18% that developed a foodborne illness. So food safety works. Just a few key points that our patients should have education on. cross-contamination, the food danger zone, getting food either heated up above 140 degrees Fahrenheit or so. I know that's different Celsius, and getting it below 40 degrees Fahrenheit in the refrigerator for storage, not having it at room temperature for more than 2 hours. Some key foods, at least for my kids, we focus on deli and luncheon meats. They don't like it when I tell them they have to have heated deli meat, but it is important for listeriosis risk. Many of our families are pursuing more, quote, natural foods such as raw milk and honey. These are just not recommended for transplant recipients. Food choices when traveling, especially if we're traveling to foreign countries, there's a higher risk of incidence of food safety issues, and checking well water if a patient isn't having standardized water that's been tested. Again, this is from an American website, but I think the concepts are universal, that we want to use different cutting surfaces for meat versus vegetables, want to really clean our hands, our countertops. I've included the basic food safety guidelines for getting food temperatures to, and then again, quickly chilling those foods right away. Again, an American reference, but one that is all ready to go that may be helpful for your patients. I've included the hyperlink for this for your reference. It is an already put together food safety document. In fact, in my facility, we just print this and give it to patients and families for our pre-transplant education, post-transplant education, and then if we need to remind them along the way. So why reinvent the wheel? This is an already put together booklet made specifically for transplant recipients on food safety. Okay, so that brings us to the end of our materials. We have about 10 minutes left. 8 minutes left for questions and answers. And I'm happy to take any questions that you have at this time. I appreciate your attention. Of note, my references are included in the PDF. I had a lot of them, so we don't have them on the screen, but if you want to know what I used for this presentation, it is in your PDF.
Oh, that's great. Thank you so much, Chris. You packed an awful lot of information into the time there. We do have a few question and answers, so I'll try and get through those before the hour. So the first one we had in was, how quickly do potassium and phosphate levels take to drop to normal post-transplant?
That's a great question, and it's really individualized. So I have patients that, so typically immediately after transplant, unless you have some pretty significant ATN, lab levels are normal during the admission post-transplant. However, it's more the long-term issues that we're worried about in those first 3 to 6 months. Now, some of my patients never have potassium issues. It sort of just depends on the patient. If they're on a lot of tacrolimus, they often have to limit potassium until those medication levels can be, typically they're tapered over time, and we see the most medications at first. So they may only need to limit potassium in those first couple months. Some of my patients, their potassium levels remain totally normal, even in those first couple months after transplant, and we don't really need to limit that. So it's really watching those lab values. And I've had patients who've needed to limit it long term, that need higher levels of medications to maintain their transplant. Phosphorus, it really depends. As mentioned, good phosphorus control is important pre-transplant for better outcomes post-transplant. If we can avoid that parathyroid from getting enlarged and having to dump phosphorus out of the body pre-transplant were less likely to have issues post-transplant. So it really depends on how well phosphorus was controlled pre-transplant as to how long we're likely to have hypophosphatemia post-transplant. And again, it's very individualized. It lasts longer for some patients. Some lucky patients don't really deal with it at all.
Brilliant. Another question we've had in is probiotics. Do you have general guidelines for use of probiotics after transplant?
Oh, that is a whole nother webinar. I appreciate the question, though.
We'll get you into that one, Chris.
I actually did a webinar in North America on probiotic symbiotic use through the spectrum of CKD. And I'll tell you what, transplant is really controversial. And in fact, that British Columbia drug nutrient interaction website I mentions probiotics as an absolute no. But there's some really mixed data. I personally have used probiotics, just some basic over-the-counter probiotics in some of my post-transplant patients with diarrhea, and seen a pretty significant impact. There's not a lot of data in kidney and none in pediatric kidney. There was some presented at the National Kidney Foundation meetings a few years ago of a group that was using probiotics in adult post-transplant patients that had some really good outcomes. The best data is in liver transplant, showing that they could prevent infection. And I guess the controversy really lies in, we know probiotics aren't always regulated. And there are case reports of overgrowth of probiotic induced bacteria in the gut, but they're case reports. And I think, anything we give is going to have a slight risk, where there's also data that shows that infections are such a big risk for our patients, and the side effects from having chronic diarrhea, for nutrient loss, for needing higher level of medications. The argument in the probiotic camp is that if we can give some probiotics and prevent post-transplant diarrhea, we reduce the amount of medications, nephrotoxic medications, that our patients have to get, and that the benefits outweigh the risks of probiotics. And preventing infection can prevent allograft loss, hospital time, etc. So there's really two camps of thought. I would say if you choose to use probiotics or prebiotics or whatnot, be very careful that it's regulated. Maybe have your pharmacy test any supplement that you're going to carry in-house, and be very aware that they're on probiotics and the potential risks for that. But the data is really mixed. I'm probably more a little in the probiotic camp because I've seen good luck with prevention of diarrhea, but it's really up to the individual team.
Thanks, Chris. I'm gonna squeeze in one last question before our closing slides. So, do you advise, if needed, high magnesium and high phosphate foods post-transplant, or would your team go straight to replacing with drugs? I ask because we find drug replacement causes diarrhea. Drug replacement causes diarrhea in many of our children and is counterproductive.
Oh, you're absolutely right, and which is why I promote high phosphorus, high magnesium foods. I think that should be our first intervention for the reasons you mentioned, plus we get more nutrition in. From practical experience, I know sometimes it's just not enough. Sometimes we just can't get enough phosphorus or magnesium in through food. So we have to go to a supplement. Also, we don't really want to promote phosphorus additives. We know they're just not healthy for anybody. So we don't want to be promoting, like colas that have a phosphate additive. We want to promote nuts and dairy and things like that are more natural sources of phosphorus and magnesium. And certainly by promoting high phosphorus and magnesium foods, we can even possibly cut down the amount that we need to supplement. I do find with magnesium, certain magnesium preparations induce more diarrhea than others. So maybe play around a little bit with the magnesium supplement that you're using. Some induce diarrhea more than others, but and certainly we can't have a critically low magnesium, but I would definitely promote using food sources first or as a bridge so we can use less supplementation.
Thanks, Chris. That's all we're going to have time to fit in today. Thank you so much. And I'm going to just leave with some closing slides. But thank you so much for your time today, Chris.
Thank you, everyone.
Thank you for taking the time to attend today's webinar. Please complete the feedback form, which will be in the post-webinar email you will receive. The next webinar hosted by VitaFlow will be on the 16th of May and focus on kidney disease from a patient perspective. On behalf of VitaFlow, thank you for tuning in. Goodbye and enjoy the rest of your day.